Yep. All right, so welcome to Night's Watch, our film discussion this afternoon. Where would you like to start?
Can we start with whether or not a kid at home, I wouldn't risk my life in a fight, no matter what my personal reasons were, because I got, something to take care of.
Okay. So, I mean, viewing this particular film through the lens of a psychiatrist, loss of a partner. And then we see some behavior that it sounds like, I don't want to put words in your mouth, might be a little concerning to you.
Yeah, I think the movie did a lot of work to justify his personal reasoning for doing so regarding, his own identity and confidence and sense of self. But I think that he's taking some risky behaviors in the context of, what he has to lose in terms of his home situation and everything.
Given our previous discussion today, I think we could say that he does have the capacity to decide what he has to do. He understood the risks of taking the fight because he had failed his medical examination in the previous, there was one that he failed and then he ended up doing the fight, but in the kind of more less regulated fashion.
Mm-hmm.
And so I think he fully understood that his sight was at risk when he went into it, and he was able to give a reason for why he wanted to, namely, again, sense of self, as Michael was saying. And so I think he has the capacity to decide from the psychological point of view. As far as what kind of defense mechanism it is, I'm not sure. One can make the argument that it's a mature one, but if you think that there is inherent value in the fight that he was doing, I think that could be argued. So I think some people could say that yes, this is a very important good reason. This is the way that he's channeling his grief and his pain into something that is in theory productive. However, one could also make the argument that it's after a missensed understanding of pride. One could say that it's about pride, and that's a little bit of an immature defense mechanism because it's not very ego protective.
And when I missed the defense mechanism that you initially mentioned? Anyone?
I'm blanking on what I said.
Was it sublimation?
Yeah, that would make sense. Yeah.
That would be my guess.
Yeah.
Now, be careful on shelf exams.
Sure.
And as much as we're discussing ego defense mechanisms in the context of Born a Champion, when you usually see the clinical vignette on a shelf depicting aggressive behavior, fighting, acting out is usually the single best answer. But acting out is an observable action on an impulse. That does not fit here. This was a sanctioned bout. He trained for it, and therefore it's a job. And a job / art are merged here. Usually sublimation is thought as an artistic expression. Both jobs count, and so does his. So I agree with you. I think this might be sublimation, which would be a mature defense for whatever that's worth. That's the original classification system from Valiant, which may or may not be applicable in the new millennium, but it's probably clinically more worthwhile to discuss in terms of productive versus maladaptive.
Was it possible because I was listening to the conversation with the doctor, and he was telling him about all the eye trauma that he had and the sheer the intensity of the injuries. Is it possible that it would only affect his eyes and not his brain at all? Because they didn't mention anything to him about brain function or that if he had some kind of traumatic brain injury. But you would assume if you're having that much trauma and you're getting hit in the head, that there's something there that they just, I don't know, maybe didn't tell him.
Yeah, you hope he would undergo evaluation for chronic traumatic encephalopathy,
Yeah.
right? And hopefully it's only the retina, if we could say that, right?
Well, that's what I was saying. Like, is that even possible? I mean, for
Yeah.
it just to be localized to.
Yeah, that happened to Rocky Balboa.
Yeah, he could just have an eye problem without having some sort of brain damage, but I don't know if they evaluated for like cognitive ability.
Yeah, I didn't see that. Yeah.
Yeah, that's why I was like, why didn't they do
You
that?
know why you didn't have a TBI.
Yeah.
Yeah,
Oh,
well,
I had
that's,
so much
it is a
fun.
concern. Yeah, it's a concern. All right, so sublimation, certainly evaluation for traumatic brain injury and perhaps even chronic traumatic encephalopathy. And then you had mentioned the way he's grieving or the way he chooses to go about grief.
Yeah.
But grief and bereavement, largely interchangeable terms. If you really want to hyper-focus on it just a little bit, grief is the feeling or emotion, whereas bereavement is the syndrome. But otherwise, we usually interchange those terms. By definition, either is defined through the condition not being clinically significant. Right. So if someone is bereaving, if they are part of or demonstrating a grief reaction, by definition, not clinically significant. If the individual is also manifesting some clinically significant impairment in functioning or clinically significant distress, then we have to move beyond those initial terms.
Do you think he would qualify for that? Like,
That was my-
after 6. Well, no. That's. I guess I'm just so curious. I feel like a lot of other things. I mean, like that specifically in psychiatry has always really fascinated me because people say that there's no right way to grieve, but like, so I just wonder how you even evaluate that. Like, I know you would measure like how much time has passed and like how close the person was.
Well,
to the
less
bereavement,
quantitative, more qualitative these days. So qualitatively, that line is always clinically significant distress or impairment. So if you were to ask him, those closest to him, if he was demonstrating or experiencing any clinical significant distress, what do you think the answer would be?
I mean, I would say so. Maybe.
As a result of the death of his loved one, right? So maybe not just a grief reaction, maybe not just bereavement, but then what?
I know that's why I'm like,
I don't remember the time frame, but
it was
could be
6 months, I
depression.
believe.
Persistent complex bereavement disorder.
Yeah, that mouthful, right? Yeah, exactly. AKA complicated bereavement, which is not going to be on an exam. Persistent complex bereavement disorder is. So you're going to have to remember those, or at least the people identify them on a shelf, right? Yeah, yeah. And then as part of the treatment plan for persistent complex bereavement disorder, what do you think needs to be essential?
Psychotherapy.
Yeah, in terms of planning. What else?
In terms of medication.
Part of the evaluation for medication is what? What do you imply?
Like MDD.
Yeah, yeah. The risk that this condition poses for future major depressive disorder, right? And here, for treatment planning, you want to really accentuate the protective factors, and you want to identify and address the risk factors, right? So that's going to be part of the treatment plan, and therefore have some kind of a risk assessment in terms of developing or evolving to major depressive disorder.
And his parents, the thing about his parents was like really briefly mentioned that he said his dad killed his mom and then committed suicide. So that's pretty significant.
Mm-hmm. Yep. Again, all these risk factors are biopsychosocial, biological, would include heritability, and certainly family history is significant here. Mm-hmm. Any evidence of Siggy caps in this movie? And if so, what did you observe?
Absolutely guilt. That was one of the first things mentioned. Is he blamed himself for his wife's death. Definitely depressed mood. I think it's implied his sleep wasn't great, but a lot of things weren't demonstrated like outright. And then he mentioned some like at least past suicidal ideation. He said if it wasn't for his son, he wouldn't even be around anymore.
Yep. So are you leaning towards diagnosis of major depressive disorder?
I think what we see, we can't meet criteria alone.
Persistent
But
complex bereavement disorder trump the MDD?
No, opposite.
Okay.
Yeah,
Really?
yeah, opposite. If he meets criteria for depression, he's got clinical depression. Yeah. So there's two ways of looking at this. One would be to nerd out, watch this movie, take notes, and check off SIGI gaps. Magic number is 5. That's noteworthy in terms of examinations. It's noteworthy during clinical interviews as well. On the other hand, to approach this film like a shelf would allow for a single best answer, meaning that on the shelf exam, I would hope that if you had a vignette that demonstrated the exact type of and number of symptoms that the movie does, and major depressive disorder was answer A, generalized anxiety B, schizophrenia C, and somatoform disorder D, you wouldn't leave it blank saying, nope, not 5, right? So it's fair to approach movies like this, phrasing their question, do you think he has major depression? Not necessarily does he reach the exact number of criteria for diagnosis. And the answer is yes, right? We already talked about psychotherapy. Psychotherapy, if engaged, and hopefully you did, at the level of persistent complex bereavement disorder is not going to change here. I mean, if you identify anything in the interim, sure, you're going to address it. But for all intents and purposes, hopefully he's already engaged in psychotherapy. Unfortunately, it did not alter the course, and now he's diagnosed with depression, major depressive disorder. Next step? Sorry?
Like think of medication trials.
Yeah, so what are we thinking here in terms of a medication trial?
I feel like it really depends on his brain. Like, I don't know. I guess you would have to take that into account. Like,
So, I mean,
I don't know. I don't know if any of the.
let's say
like,
no
first line-
overt evidence.
You know.
Yeah, even if there was even MCI, it's not going to probably change your decision in terms of antidepressant therapy. So you're thinking an SSRI class?
Yeah.
Okay. What in the patient's history, whether it's actually demonstrated in the film or not, I don't know, might actually support the SSRI here as a first-line treatment? And think about that for a second. Let's answer the first question first. What are the other first-line treatments for major depressive disorder?
Like Wellbutrin.
Right? So the NDRI, right? The norepinephrine and dopamine reuptake inhibitor. There's only one in that class. That's bupropion, Wellbutrin.
Tazepine.
Good. And the combined agents, right? There's 2 forms of combined agents, generally speaking. Those that address both serotonin and norepinephrine, the SNRIs, that block reuptake, and those that address those same neurotransmitters but at the receptor level. Okay. Your answer was Remeron or mirtazapine, which is the receptor level medication. What are some examples of those combined agents that address those same neurotransmitters, albeit at the reuptake level?
Vaccine.
Good. Right? Sorry?
As otherwise.
Yeah, SNRIs,
Yeah,
right.
sorry.
Yeah, yeah, and venlafaxine is the oldest, right? Good. And then anything else?
Duloxetine.
Duloxetine would be in that combined, yep, and focused primarily on the reuptake, or in this case, blocking reuptake of both the norepinephrine and serotonin, or serotonin and norepinephrine SNRI, right? The other way to think about this is they're all first line, with the exception of the TCAs and MAOIs.
Mm-hmm.
That's really right. So, and that includes, by the way, electroconvulsive therapy. Right? That includes electroconvulsive therapy. Right? Everything is first line. Now, again, if you want to expand that conversation, deep brain stimulation and transcranial magnetic stimulation would be considered second line agents, just because of their efficacy in terms of, well, one, efficacy, but the deep brain stimulation is invasive. So in each case, second line agents, the ECT. All right? But ECT and all the other medications, with the exception of the TCA and MAOI, are first line here. All right. All right. How do you go about choosing between these first-line medications?
I think that we can consider that he potentially has PTSD as well, like traumatic past, and so then that could lean towards SSRIs because they're also first line for PTSD.
Yeah, multiple SSRIs have primary indications, alternative indications for post-traumatic stress disorder, and yes, I believe this movie is about post-traumatic stress disorder as well. His signs and symptoms, his anxiety signs and symptoms do appear to be greater than 1 month, so not likely acute stress, but post-traumatic stress disorder. Generally speaking, even if Born a Champion was not about PTSD, there's still a case to be made for the treatment of depression with the SSRIs if the individual is anxious in general, right? So are you a nervous person is a wonderful single question screen. If they answer no, that has about a 99% negative predictive value for anxiety disorder, right? If they answer yes, of course, you can have false positives, so please ask more questions. But anxiety in general, in the setting of major depressive disorder, should go with a SSRI. The other two serotonergic signs, in addition to depression and anxiety, history of suicide attempt. Right? So this comes up on boards all the time. Which metabolite has been found in clinical trials to have or be at lower levels in CSF of individuals who have completed suicide? More specific.
5-HIAA.
Perfect, right? 5-HIAA. So given that, if the past psychiatric history is significant for a suicide attempt, that screams serotonin dysregulation. And if your patient rolls in for major depressive disorder, even without co-occurring anxiety or even PTSD, think SSRI. And then finally, sleep is largely a serotonergic phenomenon, or is a serotonergic phenomenon. If your patient has difficulty sleeping outside of a major depressive episode, that should also be a red flag that something serotonin related is going on. Now, in the absence of those, all of a sudden you've got to reconsider Wellbutrin instead of the SSRI. If your patient is depressed with no evidence of insomnia, with they're answering no to being a nervous person and no history of suicide attempt, you've got to ask, or at least, and by the way, you've already asked these questions, so now just refocus on them in your write-up. Number one, any tobacco use disorder. Right? That's a dopamine phenomenon. Okay? If they CAGE positive, and that means answering one of the CAGE questions, yes, one. Right? Number three, any substance use disorder. Number four, obesity. And then finally, number five, difficulty concentrating, especially if outside of the context of a major depressive episode. Those constellation of symptoms are largely due to dopamine dysregulation. So in the absence of any of those three serotonergic factors, endorsement of anything from proverbial column B should have the clinician prescriber strongly consider the medication bupropion in the treatment as a first-line treatment of major depressive disorder. Of course, if you have checks in both columns, go with the combined agent. When in the world would you go with a TCA?
They fail first line. They fail first line.
Multiple different first
that we
lines.
can
So
switch within.
Right. Usually on shelf exams, and it's consistent with the APA guidelines, 2 failures. Right, 2 failures. And they could be both from the same class, but 2 failures. Okay. What else on a shelf exam is usually necessary for you to feel comfortable choosing the TCA as the single best answer, treatment of depression?
do you also have like migraines or something?
So that's a great point. So that goes under the general rubric of there must be an indication. Now, it seems straightforward because, okay, well, you're talking about antidepressants. Sure, yes, there needs to be an indication. Be careful because about 50% of the time, the vignette will give you an illness other than major depressive disorder. So you have to understand that there are additional or alternative indications for these TCAs, and they count. Right? Good point. God bless you.
Also for like OCD.
And
For, like,
which TCA? Good. Good. Yeah, exactly right. Perfect example. Good. Right? Clomipramine for obsessive compulsive disorder. There's a great example and a very common board example, yeah, as to when to prescribe one of these agents, the TCAs, as a first-line therapy. And the other thing, the third and final criteria that will allow you to choose the TCA as the single best answer is that there must also be an absence of contraindications. So always think cardiopulmonary. What if no contraindications are listed in your clinical vignette? Is it then reasonable to assume there are none?
No.
When is it then reasonable to assume there are none?
When it states that there are none.
In clinical practice, never. On shelf exams, in the absence of
Any-
implicit information, young females are always healthy on shelf exams. So, early 20s female with no documentation in that clinical vignette of absence of cardiopulmonary, absence of contraindications, period, can be deemed healthy, and therefore you can still choose the TC as the single best answer.
What about young men? They not healthy?
Intermediate. Yeah, they're healthier than old men, so thank you for that. But otherwise, they're not as healthy as young women. Yeah, the two intermediates are older women and young men. You usually won't get that on a shelf. It'll usually be a young female. That's the operationalization of health. Questions about TCAs? What are the side effects? Sorry?
Do you use TCAs?
On consults, no. Outpatient practice, yes, but not since I've joined the consult service. When you discuss medications, there's a couple of ways to kind of address it. Approach studying for boards. First, approach it as a class, and then look at the singular agents on what you might need to know about them to separate them from the rest of the class. And when you're doing that, always think of the proposed benefits and the anticipated risks. Right? So for the TCAs as a class, the proposed benefits, number one, of course, improvement of depressive symptoms, but don't forget alternative indications as well. Clomipramine for OCD is a great example. Imipramine for panic disorder, another common board example. At what risk? As a class, what risks or side effects might you be concerned about?
Anticholinergic, like flushing and urinary retention.
Mm-hmm.
Mad as a Hatter.
Exactly right. That's right. Yeah. Others?
Cardiotoxicity.
Mm-hmm. If you're cardiotoxic, I think they're what, class 1A? This antiarrhythmics, right? They're sodium channel gator, right?
Mm-hmm. Yeah.
Okay. Any others?
Histamine.
Yeah, I think so.
Antihistamines are very sedating, right?
Seizures, coma.
Yeah, seizures, good. Yeah, seizures. Two more common ones that present on exams. Orthostatic hypotension,
Serotonin.
and they direct the drug. Well, we'll talk about that separately. The other biggie is metabolic abnormalities, right? Weight gain, diabetes, dyslipidemia.
That also happens with second generation antipsychotics. Right?
So say that louder.
A second generation antipsychotics?
Perfect.
Is there any other class that would?
Those are the biggies, right? So for both of these classes of agents, both of these classes of psychotropics, the acronym is STOMAS, S-T-O-M-A-S. Number one is sedating. Number two is torsades and other arrhythmias. O is orthostatic hypotension. M, metabolic. A, anticholinergic. And then finally, S, seizure. And they count for both the tricyclics as well as the atypical or second generation antipsychotic agents. The difference, I don't know if you'd be asked this, metabolic, a little bit of a different mechanism. For the for the second generation antipsychotics, we really don't know. Cortisol may be involved. It's not as straightforward as the tricyclics. Tricyclics, due to the antihistamine effect, are appetite stimulating, and therefore obesity followed by diabetes, dyslipidemia. That linearity, that cause and effect, not necessarily for the second generation antipsychotics. It's a little bit more complicated mechanism. Right? People who we treat with the antipsychotics, the second generation antipsychotics, without gaining weight can still become diabetic. We still check fasting blood glucose every 6 months just to monitor medications, irrespective of weight gain or not, right? That's not the case for the TCAs. So, but otherwise, stomas. Any questions about antidepressant therapy? Any additional observations in this movie?
I wonder what his physical health was like after the fight, because you see him having like extreme tunnel vision, and then he actually goes unconscious, which would mean like a really traumatic brain injury. So they don't. I mean, they show him at the end with like scars fully healed, and like he looks completely fine. So I wonder how much time has actually passed, and like, you know, how much vision he has. I mean, from the last scene, it seems like his vision is fine, but we don't really know.
He's blinded.
I think he's blind.
Oh, he is?
Yeah.
Oh,
Yeah.
wait, what, how did they imply that? Or, like, say
He was
that
like
they
looking
said
off
it?
into the distance.
Oh, okay.
Well,
I probably
it's
just
not-
wasn't looking, like, intensely enough at it then.
And how is this affect?
Good.
Right?
It
Yeah.
seems full.
Euthymic, full, right? Well, let's didactic this. What are the 5 domains of affect that an attending would expect a medical student to render an opinion on when they see a patient?
Blunted, flat.
So, intensity, right?
Yeah. Oh, that's what you mean. Range.
Range, good. The type,
Convincing. There you go.
good. Congruency, aka appropriateness. And then the final one is change pattern. Okay, so those are the 5 domains of affect. Generally speaking, for mental status exam presentations, for follow-up patients, the type of affect, the range and intensity suffice. With the other 2, congruency, change pattern, reported on if there's a pertinent positive. Right. Generally speaking. Now, again, I say this, you're going to go in Monday, do that, and it's going to be a different attending, and you're going to be told something different, so just don't blame me. Blame the resident.
Sorry.
It's all right. We went through this yesterday, right?
What is types of affect? Again?
Type is your favorite adjective,
Okay.
right? Most common, euthymic, dysphoric, irritable, anxious. Those are the top 4.
You can think of it as like the quality of it.
Yeah. Yeah. Good. Again, use those. I mean, try to use those 4 terms first. By reporting on the type of affect, it's not an opportunity to try to impress your attending for the with your vocabulary. Keep it simple. Okay. Intensity is the average intensity over the encounter. Right. Abnormalities or deficits here would include blunted. Right. So if the average intensity is a C, blunted would be a D average. And then significantly below average, or that F, would be flat. Range, normal or broad. Abnormality would be constricted or restricted. Those 2 terms are usually interchangeable, constricted or restricted. The opposite of that would be expanded. And how's his affect?
In the movie? I mean, hard to say because we only see a snapshot of it at the end. So I wouldn't be able to make a comparison.
Initial impression. I'm not going to hold you to it.
Initial impression.
You didn't see the sequel?
No.
That's because there is
I
none.
was really dynamic at the end. But
Yeah, I agree. So there's a couple of things I want to mention about this. One, is more straightforward and is going to appear on a test, and I could say that I do not believe is going on here, but it will appear on a test. And the other one is what I think is going on here, which requires a little bit more and a deeper conversation. So the easy one first. When a patient presents to you, in this case, with blindness and has a euthymic affect, thoughts? On the test, what are you thinking? Therefore, what will you look for in the vignette, and what are you going to peek at with regard to that answer set?
Conversion?
Yeah. Yeah. Yep. So that is an inappropriate affect, and inappropriate affect or incongruent affect in the setting of conversion disorder goes by what name? Perfect. Good. So that was the easy one, right? And that's the one that I don't think is going on here, right? On the other hand, how do we make sense of this? Which is not going to appear on your shelf, but is kind of cool to discuss anyway. So, why does he have an inappropriate affect, a euthymic affect, upon becoming blind?
He could have done a lot of internal work and come to peace with it.
Mm-hmm. You want to be more specific?
I don't know.
He won.
Was that?
He won.
He won. That was helpful.
And he like completely out.
Mm-hmm. What's the process in which people go through events like this to kind of get a do-over, to right a previous wrong internally? No, it's an ego defense mechanism. I mean, this fight was much more than just a fight for him, right?
Yeah.
Right? It was a second chance, right? And because he did achieve this positive outcome, I think it is directly related to that affect we see at the end. Right? That's called undoing. Okay, undoing. Right? Is there another film-based infamous case of undoing that comes to mind, where something tragic happened?
Sorry, say more
Sure.
about it.
Another fictional film-based example of undoing in a character that, similar to our character today, is also retired service, traumatic event, and has spent his career undoing the trauma in his own way, but not through MMA.
So the Sixth Sense with the guy on.
Tony Stark.
I have to look at that now. That might be a good one. Although he's not former military, is he?
No.
No.
Well, I guess he was peripherally involved in the military. But
Well, contract, right? Yeah.
I was gonna say Bane from Batman. I don't think that he was right. Yeah, because he did a wrong and then he spent the rest of his life trying to undo it. But I don't think
Yeah.
he's
Right. Yeah.
Wait, you don't think Bruce Willis's character from Sixth Sense? Because didn't he
I'm just saying not former military. I mean, just not to fit the character description. Former Marine. Traumatic event, and has spent his entire life with the process.
Shutter Island.
The movie does take place on an island, though. You're getting close. It's actually Captain Quint from Jaws.
I wouldn't have guessed the one.
We were talking about this earlier. Yeah.
Right? So,
Didn't take it, yeah.
somebody described to me that scene where Hooper and Brody enter his cabin for the first time. Remember that? Remember that?
After he saw Jones.
No? I mean, literally, every square inch of his walls are occupied by jawbones. This guy has been killing sharks ever since he was rescued on the open sea that day. That's undoing. And if either character, Brody or Quint, had recognized that, they would have never gotten on the Orca when they set sail to go after the big one. Because what Quint realizes is that what he could not undo with quantity, he was going to undo with quality. And that this was the big one. This was the one that was going to undo all of that trauma for him. Right? As a matter of fact, when they first spot the shark on the Orca in the open sea, Hooper yells out, I think it's a 20-footer. Remember the very next line in the script? I mean, Quint almost cuts him off. 25 at least, because it has to be. It's got to be the one, right? So this is Moby Dick. Right, by the way, it's a remake of Moby Dick, right? All right. Back to our film of the day. Any other thoughts, observations about our character in Born a Hero?
So is undoing like, can it sometimes be a healthy way for someone to
Oh, yeah.
like
It can be adaptive,
resolve
sure.
their trauma?
Mm-hmm. And remove the retired military, and yes, Dr. Malcolm Crowe, despite his misdiagnoses in M. Night Shyamalan's The Sixth Sense, can certainly be another depiction of undoing. Any final thoughts? Other characters? Anything? All right.
I felt like from a writing perspective, his like Marine background and his parents weren't super fleshed out and incorporated super well, and I feel like it could have focused a bit more on one or the other in terms of like how it motivated him to in the present situation. But it's just like a writing kind of comment.
Mm-hmm. Did you look anything up in the wiki?
I just looked up. If
They
it
didn't
was
have
familiar or
anything
not.
in the-
Yeah, but,
Maybe I was just looking at the wrong place, but I looked at the Wikipedia. Even under the plot, it was like 2 sentences, so no one
Yeah.
really like actually fleshed out the movie, which is frustrating. But
I just thought it was kind of like, it was a little bit cheesy at the end when the director of the UFC was like, I always wanted to meet the man that saved my son. No. That was cool.
So
but
random.
not-
He
not-
had
not
to do
much
that
of
right
it.
before he went.
oh
and
wait,
fought.
I meant to ask about that. Wait, what is he talk? What is that connected to?
Uh,
Saving his son? What was that? Like, because I heard that, I was
yeah.
like, wait, what? I'm confused.
Uh,
So
it had been established in the movie that the main character was like a former Marine.
oh, and it was
but-
that he carried out his son. Oh, okay.
Yeah.
They should have established
Wow.
that more. Yeah. That's. I was just
Yeah.
like, wait, what?
Yeah, I
Yeah.
felt like it took away a little bit from the seriousness of the situation.
Yeah.
The movie.
Well, I thought that dialogue was going to be seminal in that with that closure, that he was not going to win this fight and he was not going to walk away from it.
I thought
was
that,
like,
I
oh
thought
boy.
he was gonna bribe him actually and be like, oh, I'll give you this much money to not fight. But I didn't go that way. So.
Yeah, and that's the way things were set up, and that's why it was such a surprise. All right, well, we'll end it here. I will post. Oh, by the way, I think next week's movie, I will post this as well as me Smile.
Yeah, I've been wanting
Yep.
to watch that one.
So-
I'm excited.
But I'll post it on Twitter just to confirm. I will also post the Seinfeld episode. Otherwise, we'll take it back next week.